Hey, I'm Dr. April Reese, and I'm going to be talking to you today about contraception. This is just a slide of various methods of contraception that we'll be discussing. Anytime that we as providers are discussing or educating our clients or patients on the various methods of contraception, we need to get a history. And in that history, we need to get medical history. That's important because there are some contraceptive methods that are contraindicated with certain medical history. We also need to get family history in the same way that there's not really any contraindications to family history, but there could be a family history of medical illnesses in which a patient may be more predisposed to, such as thromboembolic events, strokes and that kind of thing, or clotting factor disorders that may play a role in the patient, or it could be undiagnosed in the patient, so that history would be important to us. We need to get an OBGYN history. We need to know where they are as far as in their family planning. Are they wanting to get pregnant soon, or is that something that's going to be further down the road? That lets us know about longevity of the contraceptive method that they may choose. We also need to know what contraceptive methods they have used in the past. Did they work? Did they not work? Why they didn't work? Is it something that the patient's not willing to do or use? And part of that goes with their personal history. There are going to be contraceptive methods that we are going to discuss that will, one, require a patient that may have to touch themselves or to be much more committed to the contraceptive method. So that makes a really important aspect of our not only our counseling on contraception, but in their decision making on what kind of contraceptive method they want to use. Also included in our assessment is any diagnostic testing that may be done. Some of these methods may require, or your facility that you're working in may require, urine pregnancy testing prior to prescribing and or inserting certain contraceptive methods. Also, any other kind of pertinent lab work is indicated by the history. I mentioned clotting and that kind of thing as far as a medical history that may be problematic for certain types of contraception. So in that kind of case, if a family member had some kind of clotting disorder, is that then lab work that you'd want to obtain on your patient? And certainly that would be something that you and the patient would need to decide. Some places also want to test for sexually transmitted infections or STIs. Pap smear, if it's also a policy of the provider and or the institution in which they are working. Ultrasonography is not typically indicated in contraception when we're counseling, but if there's any thought that there could be some abnormality in the uterus, problems with the ovaries or fallopian tubes, and it certainly might be indicated. So that's why I put that there. Some methods would be in your best interest to do a physical exam, especially your hormonal methods. You definitely want vital signs, see what blood pressure is doing. Pelvic exam, if it's indicated, with an IUD, as we'll discuss later, it will, pelvic exam will certainly be indicated. And so along with the assessment would be a physical exam. You also want to hear, listen to, just overall health of the patient, especially when you're using hormonal contraception, which we'll talk about, but heart and lungs, just kind of a good general health physical assessment for some of these, particularly the more prescribed type of contraception methods. When we're looking at choices of contraception, it's, as any healthcare that we're going to provide to our patients or clients, we want them to be a participant in their decision making. And so in order to help them and to assist them make an informed decision. Not only are we going to get that history we talked about, but we also want to know from them what the willingness to use. Is this going to be a method that they know they're not going to remember to take a birth control pill every day? They're probably not going to use that kind of method. If it's a method that requires them to be able to keep up with a menstrual cycle, and they know that's something that they're not going to do or unwilling to do, then that's not a good method for them. If it's a method that requires them to touch themselves, then that's certainly not going to be a method that's going to be good for them. So that's part of the decision-making process. Cost is another component of that process. Is this contraception going to be something that they're paying for out of pocket? Is their insurance going to help pay for it? We know medications cost a lot. Some of the oral contraceptions can cost a lot of money if their insurance is not helping them, if there's not a generic. Some of the more long-term initially are going to would cost more, such as an IUD or an implantable, and then also sterilization procedures or surgical procedures. So that's going to be even more potentially out-of-pocket money. So that's going to play an important role in their decision making. We also want to alleviate any misconceptions that the patient may have about various methods of contraception. One that I hear about all the time probably deals with sterilization or tubal ligation, and I have had numerous patients in the past tell me that they've heard of someone who's gotten their tubes tied, and then after they got their tubes tied, their menstrual cycles went awry. And that's just a misconception, because tubal ligation doesn't affect the hormone side of the menstrual cycle. It's more of a blockade. So alleviating those kind of misconceptions the patient may have. We also want to provide the patient so that they can make an informed decision about the method of contraception they want to use. Information about the various methods, how they work, the advantage or disadvantages of that method, any danger or warning signs they need to report, and if there's any kind of backup method that's needed either on initiation, or if something is missed or removed, do they need to have use a backup method? Or if certain medications may interact with their contraception, they may need to use a backup method. And so that's always important to discuss with them. The first types of contraception we're going to talk about are the natural family planning or fertility awareness methods. Sometimes it's abbreviated to FAM, or behavioral methods of contraception. Abstinence. Well, I think most of us know what that means. That means we're going to abstain from intercourse. It certainly will protect us against pregnancy, but will also protect us against sexually transmitted infections as well. But it also is a choice, and it's also maybe a difficult choice for some people. So abstaining certainly is by all means the ultimate method. Your fertility awareness methods, these are methods in which one patient has got to be very committed to doing these, and it takes some education and teaching, and there are some providers who are just not up to date or knowledgeable about these methods. So when we teach these methods, we got to give them specifics about each one. But basically, the patient is just using their own awareness of their body and their fertility, and perhaps some tools, and for their contraception. And so the first one is the cervical mucus ovulation method. During our menstrual cycle, our cervical mucus changes depending upon the hormones involved. As we get closer to the time of ovulation, the cervical mucus becomes thin and clear and egg white like. If you may remember in your earlier nursing programs, when you learned about the menstrual cycle, you'll remember that it becomes springbarky, so it's stretchy. So that's where the egg white light comes in. And so in doing that method, the woman has to be aware of those changes in cervical mucus, and potentially may have to touch herself to get a sample of that cervical mucus if it's not apparent from the outside. And so that's going to play a big role if the patient is going to want to be able to do that. The cervical mucus method is also called the Billings method. And just because of the high estrogen that's going on during that time just preceding ovulation, that causes the changes in the cervical mucus. And once we start seeing that sign of that egg white-like appearance of the cervical mucus, they can be considered fertile up until 4 days after that. And so those would be the times that they would want to abstain from intercourse. Basal body temperature requires a basal body temperature thermometer. It's not like your usual thermometer because the increments are different. Just prior to ovulation, and we look at a normal menstrual cycle as being somewhere around 28 days, 35 to 35 days, depending on the patient. Usually in a 28-day cycle, ovulation occurs somewhere around the 14th day. And so just prior to ovulation, basal body temperature will drop just slightly. And then during ovulation, it begins to rise, but only just a small amount. We're looking at 0.4 to 0.8 degrees of Fahrenheit. That's why the special thermometer is needed. And once that rise occurs with ovulation, it tends to stay up for the remainder of the cycle. And so not only is she going to have to take her temperature before getting out of bed, before any activity occurs upon rising, but she's going to have to do it daily and keep a record of it so she can see where that change occurs. Now, there are some things that may affect that. Your shift workers, that may play a little different, so it may not be a good method for them, because naturally if you're sleeping during the daytime and at night, your temperature tends to be a lot higher during the daytime, so that may have an effect. Or if they're rotating shifts, then that's going to have their basal body temperature being off, because sometimes they're waking in the morning and sometimes they're waking in the evening. So those kind of things may play a role if they want to decide to use that method. Symptothermal method is really a combination of these methods. It's looking at just the menstrual cycle in itself. How long is their menstrual cycle? We know if their menstrual cycle is longer, the days in which they're fertile is going to be different than if it's a normal 28-day cycle, whereas a menstrual cycle that's less, their ovulation is going to occur before that 14 days. And so those are things we have to take into account. So you're looking at not only the days, which is the next method, but you're looking at other symptoms: cervical mucus changes, basal body temperature changes, and then also any symptoms the patient may have during ovulation. There's some women who have some pain during ovulation, so that might be a sign for them. Some women get more bloated. Some women have increased libido during that time. And so they would use all of those methods together. Standard days method is just typically using the days of the menses and mapping that out on a calendar to try to figure out when are probably the most fertile days. Typically, your changes in menstrual cycle duration occur in the front half of the menstrual cycle. So day one of the menstrual cycle is day one of the menstrual cycle. So the first day of your period is the first day of your menstrual cycle. And so you go from there. And again, a 28-day cycle, normally that ovulation usually occurs somewhere around 14 days. Now, we're all different, thank goodness, so that's going to happen with each of us a little differently. Typically, when you see variances, though, in the cycles in the first half, so if I have a 35-day cycle I may not ovulate until day 18, 19, 20, somewhere around there. But usually what you're going to see is from time of ovulation to the beginning of the menses, in most women, is still going to be 14 days. So you're going to get the variance in the first half of the menstrual cycle. And so using a standard dates method, they may have to, any of these methods, they're going to have to record several months of cycles to get an idea of when the fertile days may be. Withdrawal method or coitus interruptus, this is dependent strictly on the man having the ability to withdraw before ejaculation. And so that requires a lot of discipline. And it may be somewhat disappointing for both. So that's something to take into account. If there's any semen spillage even on the vulva, it could still, if it was to get into the vagina somehow, could still expose someone to a possible pregnancy. So that's just something to keep in mind. Lactational amenorrhea method. This is for your breastfeeders. When women are breastfeeding, particularly if they're solely breastfeeding, and we're looking, if you're using this method as a contraception or advising it as a contraception, these are women who are solely breastfeeding, and you're looking at about 10 feedings in a 24-hour period. When we breastfeed, prolactin is high, and so it's suppressing estrogen and progesterone. It also inhibits gonadotropin-releasing hormone and luteinizing hormone, which prevents us from ovulating. And so women who are solely breastfeeding, they may have some protection of pregnancy if they're solely breastfeeding, up to 6 months, and during which oftentimes the menses will return. Now, we don't always know when we ovulate necessarily before menses start, so that can be problematic for some women because of just not knowing. But in women, we do get some protection in breastfeeding from ovulation in women who are solely breastfeeding. So it certainly is a viable option as a contraception method. When we look at the mechanism actions of these, some of it I've explained already. Abstinence, definitely an avoidance of intercourse. Your FAM or your natural family planning methods, using the menstrual cycle or the changes during the menstrual cycle, whether it's a basal body temperature, cervical mucus, or using calendar days or your other symptoms. This is just avoidance from intercourse during the fertile days, which, can certainly, from a disadvantage standpoint, play a role in spontaneity. Because you've got to kind of plan around those days, and oftentimes libido is increased during those days, so those may not be the time that we really want to avoid intercourse, but it's the most fertile days. Coitus interruptus, again, withdrawal of the penis prior to ejaculation. Effectiveness of these methods, anywhere from 75 to 95% effective, depending on use, and so you got a great variance in how effective these are. Advantage, most of these are, because they're natural, are accepted by most religions. There's no hormones, there's no barriers, there's no devices to use. Can be very effective when used correctly. And also, the effectiveness is increased when combined with barrier methods. Requires body awareness. Women who use these methods become very aware of what their body is doing, what the menstrual cycle is doing. Possible disadvantage is no protection from STIs. It requires time to learn the cycles. It may take even as long as 3 months to get an idea of what the average cycle is like. Higher risk of pregnancy due to error. Ovulation time may change based on many factors, such as stress, significant changes in weight, medical illnesses, and so those are things that need to be taken in consideration. And these methods do require a lot of discipline and commitment. Your barrier and chemical methods. These are your condoms, male and female, diaphragm, cervical cap, contraceptive sponge, and spermicides. The sponge also has some spermicidal, so it's not just it provides both. Mechanism actions of these methods, they either provide a mechanical blockade so that sperm and egg cannot meet, or a chemical blockade, especially in a spermicidal action that kills sperm. The effectiveness, you get increased effectiveness when you combine these methods, mechanical and chemical, or use them with a fertility awareness method. Condom pregnancy rates about 15% in male, 21% in female with a female condom. Diaphragm cervical caps, pregnancy rate is about 16%. These are typical use percentages. Spermicide alone, pregnancy rate can be as high as 29%. Some advantages: condoms and spermicides are over the counter and they're readily available. They tend to be inexpensive, some places even free. Diaphragm cervical caps may be left in place for up to 24 hours, which may be an advantage and a disadvantage. Disadvantages: diaphragms and cervical caps require a provider to examine and fit them appropriately. Those along with your sponge, cervical cap, diaphragm, and sponge need to be left in place for 6 hours following intercourse. They may be difficult to insert or remove depending on patient. Spermicides, which you will use either whether it's alone and or with a diaphragm or cervical cap, can be irritating to some skin, male and female, as well as can be messy. They require additional application with repeated intercourse. Condoms, of course, and a spermicide if those are used. But if they're using a diaphragm or a cervical cap, you leave those in place, but you also apply additional spermicide on the outside of those with each intercourse. Certain lubricants, such as Vaseline oils, may break down condoms, so we got to think about that. The condoms may reduce sensation, which may be a negative on both part of the female and the male. There is a risk with these methods that you have to leave in place of toxic shock syndrome, so we always have to consider that. This is just a picture of female-male condom. They shouldn't be used together. When used correctly, they can be really, really effective. It is the only form of birth control that protects against STIs. And so when we're counseling our patient about contraceptive methods, we also need to counsel them about risk reduction of STIs. And so, as you can see, these are the only methods that do protect against STIs. So they could actually be used in combination with any of the other methods if there's a concern about STI transmission. This is a picture of a diaphragm. A diaphragm has to be fitted by a provider and cervical cap. And as you can see, it requires them to touch themselves. So if that's a negative on the patient's part, then that's not a contraception method that they want to use. They may need to be refitted after childbirth, pregnancy, childbirth, and any dramatic weight changes. So that's something also to keep in mind. When you see when you see a diaphragm in real life, you would think, "Oh my goodness, that doesn't look very comfortable." But actually, a diaphragm or cervical cap, once it's inserted, the patient should not feel that. If it's fitted correctly, they will not feel it. So it wouldn't be uncomfortable. Some women, you can get some pressure on the bladder or the urethra. Particularly if it slips down, but typically if it's well fitted, that shouldn't be a problem. This is a picture of just the various types of spermicides. There's foams, there's gels, there's film, and you can see the contraceptive sponge. That actually came off the market for a while, but I believe it's back. So various methods in which they can have a spermicide. So a little question here is, patient desires a use of fertility awareness method of contraception. Identify all that apply. A, basal body temperature. B, diaphragm. C, male condom. D, transdermal patch. E, symptothermal method. And the answer is A and E, basal body temperature and symptothermal method, are both fertility awareness methods of contraception. Diaphragm and male condoms are barrier methods. Transdermal patch is a form of hormonal contraception. And so let's look at our hormonal contraception. We have various methods of delivery in our hormonal methods. Oral contraceptive pills, injectables, transdermal delivery, vaginal ring, implantables, and then emergency contraception. Some contraindications to hormonal contraception. When studies were done on hormonal contraception back in the 60s, those were high level hormones, and so you got some incidences of things like clots and strokes and those kind of things. The risk of that's still there, and you don't see it as much with the progestin only, but it's still included in the contraindications. And so when you pull any of the little flyers from birth control pills or even an Explanon, as we'll talk about, or Depo-Provera is an injectable, you may see these contraindications still in there, and so you still have to consider those things. So contraindications to hormone therapy: anyone who has had any kind of thromboembolic, I can never say that word right, disorder. So blood clots, pulmonary embolus, those kind of things should not use hormonal contraception. History of cardiovascular accident or coronary artery disease, so stroke, heart disease, liver disease, to include malignant and benign liver tumors, history of breast cancer or any other estrogen-dependent cancers, hypertension unless it's well controlled. I've had many of women on birth control pills that have hypertension, but it's well controlled. Migraines, and that may be a little questionable. There was some your literature is going to say migraines, particularly if they have an aura. Although I've seen some women who actually had migraines improve when their menstrual cycles more stabilized. So you still got to keep that in mind. Diabetes mellitus if there's vascular involvement. Contraception or hormonal contraception may have an effect on diabetes, but more so if there's vascular involvement. So any diabetic, there are lots of diabetics who are on hormonal methods of birth control. So it's just looking at the vascular involvement and is it affecting the blood sugar. Use caution in other women who are hypertensive but controlled. You still want to monitor that, make sure hormonal methods not increasing their blood pressure. If they smoke, if they have undiagnosed vaginal bleeding, they have a history of headaches. Combine oral contraceptive pills prior to 6 weeks postpartum, and that's mainly because of the risk of clots, and also we'll talk about breastfeeding too. Or if they're going to have major surgery requiring prolonged immobilization, again, the risk of clots there. Breastfeeding, progesterone-only pills or the mini pill, and also your progestin implantables. Implants are considered safe with breastfeeding. Combined OC pills are not typically used during breastfeeding because estrogen can decrease milk supply, have an effect on milk supply. So we usually, in a breastfeeder, if we're going to use a hormonal contraception, it's usually after the milk gets established and during that time that they're breastfeeding, if their choose to use that. If I have someone who's on a mini pill and then they start weaning the baby from the breast, I usually will tell them to let me know when they start doing that, and we'll change them over to a combined pill. Your mini pills are progesterone-only pills. They're still effective. They're just a little bit less effective than a combined oral contraception. A mini pill also may be something that you could use in a hypertension patient if you were worried about the estrogen side of things, increasing blood pressure. Effectiveness of your hormonal contraception, 99+% to 92%. Pregnancy rate anywhere from 0.2 to 8%, depending on typical use. Advantages of your hormonal contraception, not related to coitus, so we're not having to worry about putting in a spermicide or a protective barrier device during the time of intercourse. May help to regulate menstrual cycle. May also help with things like acne, premenstrual syndrome, dysmenorrhea, polycystic ovarian syndrome, endometriosis. May reduce the risk of ovarian and endometrial cancers, and there's no feeding required. Disadvantages: provider prescribed, in that they have to see someone, have an office visit, go to the health department, whatever the case may be, for a provider to prescribe. There can be side effects: weight gain, nausea, headache, breast tenderness, melanoma, amenorrhea, mood swings are just a few. There's no protection against sexually transmitted infections. An oral contraceptive pill requires them to take that daily, and it should be taken about the same time every day. If they miss one, they're going to have to take it as soon as they remember, and then maybe take another one at the usual time. If they miss more than one, then they're certainly going to increase the risk of a pregnancy occurring. Also, there are some medications that may interfere with the effectiveness of birth control pills, particularly some, and not all antibiotics, but some antibiotics, and some of particularly your anti-seizure medication. So we need to, that's part of that history taking, we need to be aware of. And we also need to educate the patient about that too. They may, especially if it's an antibiotic that they have to take while they're on an oral contraception, they may want to use a backup method during the rest of that month. I usually don't have them come off the pill, because then that starts playing with their menstrual cycle. But they may want to use a backup method if they're having to take a medication, may decrease the effectiveness of it. Transdermal requires a weekly application, and they're going to change a patch every week, and then they're going to come off for a week while they have a menses, and then they start back, so they got to remember that. A vaginal ring requires for it to be inserted and removed, so that means someone's going to have to touch themselves, and then they leave it in for 3 weeks, and then they take it out for a week, which will be the time when they have their menses, and then they'll have to put one back in, so they got to remember to do that. And again, some medications may decrease the effectiveness, antibiotics and seizure medication. These are the warning signs on hormonal contraception. The acronym is ACE. And just because hormonal contraception can increase the risk of things like liver disease, strokes, blood clots, increased blood pressure, so that's where these warning signs are coming from. So your ACE. A is for abdominal pain, severe abdominal pain, which could be an indicator of either benign liver tumor or gallbladder disease. Gallbladder disease may also be a contraindication too in some patients, because it certainly may have an effect. C for chest pain, dyspnea, hemoptysis, which may be an indication of pulmonary embolus or myocardial infarction. H for severe headache, weakness or numbness of the extremities, hypertension, stroke, or migraine with neurologic problems is what it could be. These symptoms could be indicating. E for eye problems, meaning visual changes, blurred or double vision, slurred speech, again, may be indicative of a stroke or migraine with neurological problems. And then S is for severe leg pain or swelling, usually in the calf or thigh. Think deep vein thrombosis, so aches. So when we're looking at hormonal methods, oral contraception pill, mechanism of action, in a combined, meaning it has estrogen and progesterone, oral contraception, blocks luteinizing hormone surge, which happens just prior to ovulation to stimulate the release of the egg from the ovary. It also inhibits follicle maturation or maturation of the egg and therefore ovulation. Typically it comes from both sides, progesterone and estrogen. Progesterone really has also an effect on cervical mucus, so thickened cervical mucus. Remember, during our menstrual cycle, during our time of ovulation, we have that thin, egg white-like, so it makes it easy for sperm to go through the cervical canal and get in through the uterus and up through the tubes. So this makes an environment in which that's not so easy. The motility of the tubes or the fallopian tubes are slow, and again, that motility is important for helping that sperm to reach that egg. And then also because of the hormone involvement, the endometrium, which is the lining of the uterus, that during our menstrual cycle after ovulation has become thick and fluffy and a nice little environment for an embryo to embed if a pregnancy occurs. So that endometrium is less hospitable environment for pregnancy. I do want to mention on oral contraception. Typically, we're going to have these patients start a birth control pill or oral contraception, usually sometime around their menses. I usually have them do a Sunday start. That's most of the birth control pills. When you look at the packaging, it's usually a Sunday start. It doesn't really matter if it's a Sunday start, it just makes it a little easier. I usually, whatever Sundays after their menses started. So if they started today, I'd go ahead and have them start it today. If they started yesterday, they'd start it today. If they started tomorrow or in the rest of the week, I'd have them start it the next following Sunday. And depending upon the pack of pills, most of them are anywhere from 24 to 28 days. They'll just go week by week. Oftentimes there may be some inactive pills in there that just carries them through that fourth week. Sometimes there's some inactive pills and then a couple little iron pills in there. I just tell them to take the whole pack, so when they finish their pack, they just start to the next pack, so they're not having to skip any of the pills. But again, it's important for them to take them about the same time every day. Some women are going to be more or less sensitive to that change in the hours. Some will get some breakthrough bleeding if they miss one, or if they even miss it by a few hours. Just depends on the patient. Your injectable is a progestin-only hormonal contraception. So brand name, Depo-Provera, generic name, medroxyprogesterone, 150 milligrams IM every 11 to 13 weeks, and we're giving them a buffer there. You know, a lot of the literature is going to say every 12 weeks, so that's giving them a buffer. Now, there is one that's supposedly smaller in amount, maybe given more frequent, but I've not ever used it, so I'm not going to speak on it. But the one that you typically see is Depo-Provera or medroxyprogesterone in 150 milligram IM injection. Mechanism of action: it inhibits ovulation and thickens cervical mucus. Very effective, 97+% effective if used correctly. It's safe with breastfeeding or lactation. And a lot of women, they oftentimes will have amenorrhea at some point around a year. So about 30 to 50% of women will have amenorrhea or stop having a period while they're on this, which is fine. It's just hormonally driven. Disadvantages: irregular bleeding. Now, I usually tell women you tend to see this irregular bleeding in the first few months, usually when it's initiated up to 6 months. So I usually have women Try not to stop it unless it's just severe bleeding, until they get through the second to third, get to the second or third shot. And the reason being is because oftentimes they will become amenorrhea after that, and that irregular bleeding will clear up. Some women complain of weight gain, although it's typically not that much, 2 to 5 pounds. On a rare occasion, it's more than that. Oftentimes what I'll find is if they have a change in appetite, they're just not eating well or not exercising, and that's the weight gain. But there are a few women who actually will gain weight on it despite changes in their diet or exercise patterns. Headaches can be another side effect. Changes in mood may be a side effect. I tend to see changes in mood oftentimes more with the progestin only for some reason. Hair loss and a decreased bone density may also be problematic with this injectable. In fact, there is some recommendation of not using it longer than 2 years in some people, although I've seen people use it longer than that, but usually definitely not longer than 5 years consecutively. It's an injection, and there are some folks who don't want to have a shot or are scared of shots, so that's going to be problematic for them. So if they don't like shots, then this is not going to be a good method for them. Best time to give it, usually giving it within the first 5 days of the menses. So when either on their period or right when the menses start is the best time. And hopefully they won't have as much of the breakthrough bleeding. Transdermal is a patch. Mechanism of action is it releases small amounts of estrogen and progesterone through the skin to suppress ovulation and increase cervical mucus thickness. They change a patch weekly for 3 weeks, and then they go 1 week with no patch. It's about 92% effective, so it's still pretty effective. They don't, during those weeks, they just got to remember to change the patch. Side effects, again, similar to any other hormonal: breakthrough bleeding, breast tenderness, headaches. Some people are sensitive to the adhesive. There is a little bit more risk of venous thromboembolism with a patch for some reason. I think there's a little bit more maybe absorption of the estrogen that may be causing that. It may be less effective in women weighing more than 90 kilograms or 198 pounds. So those are some things to take in consideration. Vaginal ring, and this is a picture of a vaginal ring. Mechanism of action is that it releases a small amount again of estrogen and progesterone continuously to prevent ovulation. Again, with typical use, about an 8% pregnancy rate or 92% plus effective. The ring is inserted into the vagina and it stays in place for 3 weeks and then is removed for 1 week. So again, because it's got to be inserted and removed, patient's going to have to touch themselves, so they got to be willing to do that. It typically is not felt, and it shouldn't be uncomfortable. It's not something that has to be fitted. There's not different sizes. Disadvantages, one again, has to be inserted and removed. Side effects, breakthrough bleeding. Sometimes because it is a foreign object in the vagina, some women will get some discharge. And sometimes with all the hormonal contraceptions, there can be some changes in discharge. Some more, some less. But because that is sitting in the vagina, there can be somewhat of a, if you will, not an infection, but an inflammatory response. And so the discharge may change. Discomfort if they feel the ring. Typically they don't feel the ring, but if they do feel the ring, there might be some discomfort. The ring can be taken out. Typically it's not felt on intercourse, but if there's an issue with that, it can be taken out, but not for more than 3 hours. If it's taken out or left out for more than 3 hours, a backup method needs to be used until the ring has been back in place for at least 7 days. I'm old-fashioned, so if you're uncertain, I always say backup method, particularly with any of the hormonal contraceptive methods. Implantable. It used to be called an implanon. Now it's called Nexplanon in the United States. And this is the same, just a picture of the little rods and the little device. It almost it's like a little trocar that you inject it in. And it's a pretty cool little procedure. The provider does have to be trained in order to place one, so that's not just anyone can do it. You have to go through a training to do it. So it's a progestin implant, Nexplanon, edonorgestrel implant. The rod is very small. It goes into the upper part of the arm, a few centimeters above the elbow, kind of on the inner aspect, and it goes just up underneath the skin. There's a little incision that will be made, and then we use some local anesthetic to numb that little area, make a little very tiny small incision, and then it just, the applicator, as you saw on the previous screen, just places it right in there, and then usually just strip over the and there's some nice little YouTube videos on insertion. Anyway, it releases progesterone continuously to provide 3 years of contraception by inhibiting ovulation and thickening cervical mucus. So advantages, it's long term. So if someone's wanting to get pregnant in a year, this might not be a good method for them, because it will be a waste of money. Cost is going to be a disadvantage on this, because up front, particularly if insurance doesn't pay for it. So 3 years of contraception. Amenorrhea may occur in some women. In fact, I see that a lot after a few months and they stop having a period. It is safe because it's progesterone only, so it's safe in lactation. Body weight does not tend to affect it as much like you see with the patch. Disadvantages, again, it must be a trained provider to insert. Side effects, again, we can have menses irregularity, just, that off and on kind of bleeding, spotting, whatever. You can also get any of the other side effects that you can see with the other hormone methods. Sometimes I also see changes in mood with this one as well, more so than sometimes the other one. So I always have I'll watch out for that. Me being a psych nurse practitioner, I'm always looking at for causes and changes of mood that may be physiological and not psychological. I will say that in women who like their Nexplanon, you can actually, when it comes time to take one out, you can take one out and put it right back in the same day. And so that's not a problem either. I'll just quickly mention the hormonal emergency contraception. These are basically just taking high-dose birth control pills. You're just taking several at one time, depending upon which plan it is. Plan B is popular. So it's just like, taking a oral contraception, and you're just, taking 2 to 4, whatever the dosing is. So all the same contraindications pertain to this as any hormonal contraception. It must be taken within 72 hours of unprotected intercourse to prevent pregnancy. It's not effective if the person is already pregnant. And it should only be used in an emergency and not as a regular form of contraception. As you can tell, just the risk involved of using multiple times of a high-dose oral contraception could be problematic in some women. So the question, identify the acronym of the warning signs patients using hormonal contraception should be educated on. IUD, PAINS, PAINS, family, or FAMILY, or ACHES, ACHES. And of course the answer is ACHES. Abdominal pain, chest pain, headaches, eye disturbance, and severe leg pain. Intrauterine devices, or IUDs. This is a picture of IUD, a couple of IUDs, one hormonal coated over on the left, and then the copper T on the right, and then at the bottom is just a picture of what an IUD looks like in a uterus. Again, a provider will have to insert. So there is going to be a need for a pelvic exam during the insertion of an IUD. The uterus is sounded, which means we're going to use a little device that goes up through the vagina and the cervix. Cervix is the opening of the uterus, if you remember from your anatomy, which is what opens and dilates when we're in labor for the baby to come out. But it is also the way we get an IUD in. It's also how menstrual blood flow comes out of the uterus as the endometrium sloughs off at the end of our menstrual cycle, or the beginning of our menstrual cycle. And so a uterine sound is just a little tool that we use that goes up through the cervix into the uterus to measure the uterine cavity. You don't want, an IUD insertion is not something you want to force because you can perforate the uterus. But you can see it definitely is an invasive type of process. And so that makes a difference. It can cause, anytime you go through the cervix, it can cause some cramping, sometimes some bleeding. And so that's something I'll tell women about, is you may experience some cramping as we're putting this in. It may last a little while after we get done. Someone would like to take a little ibuprofen or something like that to help prior to. We usually also insert an IUD oftentimes while patient is on their menses, because the cervix may be a little bit more dilated or opened while they're on their period, which is going to make insertion easier for them. Easier for the provider, you as a provider, but easier for them as far as cramping and that kind of thing goes. Mechanisms of action, copper T or copper T 380A, also known by the trade name as Paragard, produces changes in the uterine and tubal fluids, impairing sperm ability to reach the fallopian tubes. And then your levonorgestrel intrauterine system. These are often known by their brand names as Mirena, Kalina, Scala, Laletta. These are progesterone coated, so they're not a copper T, they're progesterone coated, which causes thickening of the cervical mucus, inhibits sperm mobility, prevents ovulation in some, and prevents implantation. Both of these IUDs provide a sterile inflammatory response resulting in a spermicidal intrauterine environment. So it just makes the intrauterine environment not friendly to sperm and or pregnancy. So very, very effective. 99.2 to 99.9% effective. Other advantages long-term, 3 to 10 years. The Scala is 3 years. Mirena, Kalina, and Laletta, I think, are 5 years. And then your copper T is 10 years. So long-term, again, if someone's wanting to get pregnant quickly, this might not be a birth control for them. It's continuous. It's pretty low key after it's inserted. Scala is the smallest one. In fact, it used to be that we didn't recommend women have an IUD unless they had had children before, which is because it was uncomfortable and sometimes difficult to get in because of the cervix not having had open before. The Scala is actually a smaller IUD, and so you can actually use it in women who have not had children. And that just may be old school of me in my thinking. But we used to not even recommend an IUD before in women who hadn't had children. But now we do. Disadvantages, cramping and heavy bleeding can be the main symptoms you see with IUDs. And I find that patients either love them or hate them, and it's usually because of those reasons. You get more of the cramping and heavy bleeding with the copper IUD, because with your ones that are coated with progesterone, it actually may help with the cramping and bleeding. In fact, I have some women who have a progesterone-coated IUD who hardly have a period at all because of that. They're getting just enough of the progesterone on that coating to not build up a good lining during their menstrual cycle. So they may have very, very small amount of bleeding during their menstrual cycle, if any at all. But always remember, cramping and heavy bleeding, two of the main side effects. Again, provider has to place it, so it's not something that, that's certainly an office visit and some expense, right off the bat up front. Expulsion could be a problem, so there's a need to periodically check for the string. Typically, when we go back to that slide, the previous slide that has the IUD and then the little string, you can see the string that's kind of outside of the cervix into the vagina. So usually we cut that string off, and we just have the patient to particularly after their menses, just check and make sure that a string is about the same length. If you see that it's longer, might be a thought to come in, or if you don't find it at all, might be a reason to come in and just have it checked. The strings are very thin, almost kind of a filament material. I want to say fishing line is the best thing that comes to mind, but it's very thin, very thin. So sometimes they can get wrapped up on the back side of the uterus and they don't feel them. So if they don't feel it, they do need to come in and just get someone to look and make sure that the IUD has not been exposed for some reason. We should not use them with women who have had recent or recurrent pelvis infection. That should be pelvic, not pelvis infections, like pelvic inflammatory disease, recent history of sexually transmitted disease, because this can actually turn into a pelvic inflammatory disease. If they maybe a little bit higher incidence of ectopic pregnancy with the IUD, so women who have had a history of ectopic pregnancy may want to not use them. Women with bleeding disorders, especially if you're worried about heavy bleeding, and for obvious reason, because it is going inside the uterus. If there's any kind of uterine, particularly structural disorders or other uterine abnormalities, may not want to use in those women. And then just because of it's an access, you've got a foreign body that's there with a string in the vagina. We used to really advise against using it in women who had multiple sex partners, just because the risk of STIs were so much greater. And with STIs, you got an increased risk of pelvic inflammatory disease, which then can cause scar tissue in the fallopian tubes and can cause sterility. So that's also a consideration in women who have multiple sex partners with the use of an IUD. And then our last method of contraception is sterilization. Mentioned it on here because you will see women ask about it still, but it's no longer available right now, is transcervical sterilization. Escher was the brand name. They took it off, the company took it off the market in 2018. They said because of business reasons, but there were women that were having some side effects, whether it was anything from cramping to vaginal bleeding, nausea, vomiting. There were a few that had perforated tube or uterus because of it, or it moved. And so I think there were maybe some medical issues, but again, the company says it was more of a business reason, and so they took it off the market. But basically, it was using a non-surgical insertion of a small coil, and I'll show you a picture in just a minute. And then that coil was inserted up through the vagina, through the cervix, through the uterus, into the tube on each side, and then left there. And so the coil over a few months will develop scar tissue, and as that tissue grows, it blocks the tube. So there is a little period of time for that to happen. Following the procedure, they would certainly need to use other contraception methods until they get some assurance that those tubes are blocked. And that's done through a hysterosalpingogram. So that's another little procedure that they have to go through, where they run dye to make sure the tube's blocked. This procedure was performed at a physician's office, and pretty high level of effectiveness, but again, not available now in the United States. And in fact, I think they took it off the market in other countries in 2017, in the U.S. in 2018. But you still may have women asking about it, and you certainly may have women who've had the procedure done. If they've had the procedure done and they're not having any problems, there's no reason to remove it. So other sterilization or surgical sterilization in females, tubal ligation. So this is cutting, usually cutting and or occluding with either clips or rings the fallopian tubes to prevent pregnancy. Again, it doesn't affect their hormone, it just affects the ability of egg and sperm to meet. You may have heard the old saying, get them cut, tied, and burn. And that often, depending on the provider, and usually this is done by a physician because it is surgical. It's either cut, and then it's usually burned on the top, and then either clipped or tied with some suture. And then a vasectomy. So let me go back to tubal ligation. So that is usually done in a hospital setting, oftentimes outpatient. If it is done right after delivery, of course, if it's during childbirth and it's a cesarean section, they will go ahead and do tubal ligation then while they're in there. If it's a vaginal delivery, the uterus is still pretty high in the abdomen up around the umbilicus, so it's an easy access to be able to get to typically to get to the tubes. And so they will just make a small incision right around the umbilicus and do the tubal ligation there. If it is someone who hasn't recently had a pregnancy, then it's a laparoscopic procedure. So usually outpatient, go home the same day. But usually, again, either in an outpatient surgery center or hospital setting. Vasectomy is for the guys, and that's an office procedure, but it's still a surgical type procedure. So it's the cutting, tying, and removal of section of the vas deferens to keep sperm from leaving from the testes entering into the penis. Effectiveness of these, 99.9 to 99.85%. There's a very small pregnancy rate. So I always tell women, if you ever think you're pregnant, just because you had your tubes tied, always get that evaluated, because there is a very small pregnancy, can be a small pregnancy rate. Advantages is permanent. You got to consider it permanent. Not anything you have to do with. You don't have to insert anything. You don't have to take anything. So it's permanent. Disadvantage, it's permanent. There are possibilities that whether it's tubal ligation and or vasectomy may be reversed, but it's oftentimes not successful. Insurance a lot of times will not pay for it, so that's going to be an out-of-pocket expense for the patient. So that's something they really want to consider. And if choosing this method, are they done with having children? It's a surgical procedure. And so with any surgical procedure, there's risk. Typically, infection and bleeding are the two main risks, but there's risk. If there's any anesthesia given, vasectomy is usually local anesthesia. Tubal ligation is usually not, though it may be some general anesthesia, so that's something to consider. Vasectomy may take 3 months or longer before they're considered sterile, because there could be sperm in the tract outside of the vas deferens, so you've got to give that opportunity to clear. So the guys will have to have a semen analysis done periodically until that's showing no sperm count in the semen, and then they're considered sterile. And then, so pictures on this next slide are, first, just a picture of what the little coil looked like with the Escher. And then second picture is showing the uterus with fallopian tube, and oftentimes you will see that they may actually have tied it. When I used to do surgery, the physicians I worked with, they would tie the tubes on both in two sections, cut those sections, and then cauterize the very end of the tube. There were some that use these little clips that go around the end of the tube, but they're serving as the same process of the surgical tie. And then down below is a vasectomy. So again, it's showing, basically it's kind of the same tying procedure that they did there that you would see in the fallopian tubes. And then they cut out a section of it. So you've got, again, a disruption of motility, whether in the female be for sperm and egg to meet, and then in the male for sperm to come from the testes to the penis. But it shouldn't affect their hormones. So when discussing contraception options with your clients or patients, always remember to get a history, physical exam if it's indicated, any necessary lab work, oftentimes a pregnancy test if it's usually one of the hormonal methods, or IUD insertion. Always take into account their preferences, what has worked in the past for them, what didn't work, and why. Because a contraception method is only as good as it's used. So if they're not going to use it, or they're not going to do it, or if it's failed before, then more likely it's not going to work this time either. Provide education on the various methods, their actions, the advantages and disadvantages, warning signs, so that they can have, we always want our patients to have the ability to make an informed decision. And so providing them with all the information that they can use to not only verbally, but also any literature. Sometimes we give them so much information during a visit, it's just hard for them to remember everything. So anything either electronically or written literature that you can give them is always a good thing. Talk about backup methods on initiation if it's needed, or if they miss one, if it's something like a hormonal contraception, they miss one, what do they need to do, or give them an instruction sheet that goes along with that. To me, education is, you can never have too much education, so I always try to load up my patients with a lot of education so they have something to refer back to. And of course, there's Dr. Google, but we know that sometimes Dr. Google doesn't always give us the most reliable sources. And so if you're assisting or providing or prescribing any of these methods, you want your patients to have the most up-to-date and reliable information they can have. And then follow-up is indicated on the chosen method, such as if I have a patient who I'm starting birth control pills on for the first time, I may want to check their blood pressure in 3 months, and see how they're doing with their, are they tolerating things well? They're having side effects. Have they gone away? Have they not gone away? Same with if I'm going to implant something, I may want to check that site in a few months and just make sure it's healed, make sure they're not having any trouble with it. IUD string, depending, some of this is going to be depending upon where you work and if they have certain policy and procedures in place that you want to follow or that you have to follow. On the annual gynecology exam, someone who does have an IUD in place, you could certainly mention the strings are visible on your exam. So there's kind of follow-up methods. Other than that, that's my conversation on contraception methods. I hope you guys have a great day. I am not in Anderson University's email system, but I soon will be, and hopefully maybe by the time you get to this lecture. So if you have any questions, I will be glad to answer them, even though I'm not your instructor. Dr. Wilson and certainly and the other faculty will know how to get in touch with me. If you do have any questions, I'll be glad to answer them. So again, have a great day and hope to meet you guys soon.